Thank you so much, Kaylee. So we're happy to have you all joining us tonight. As Kaylee just said, that the webinar is going to be recorded, and I wanted to say that the PowerPoint presentations tonight are all going to be available on the Hemophilia Ontario website, as well as the recording. So if you missed something tonight that you see on the page, don't worry about it. You'll be able to access it on the website afterwards, and possibly also in our member update that comes out weekly. So before we get started with everything else, I'm just going to have Kaylee pull up a short questionnaire for you, a poll, to see your comfort with vaccines that we're going to use later. It should be coming up on your screen now to get an idea of where people are at, how they feel about vaccines, and what basic general comfort level you have with everything that's going on. After this presentation tonight, we're hoping that we're going to link you out to an evaluation of tonight's program, but also some of these same questions are going to come up so that we can see if you have gotten some value out of seeing tonight's presentation, if it's increased your comfort level, and how you're doing with all of this, because we want to make sure that we're responsive with our content, with the things we present you with.
So I do see we're slowly getting some responses. I know that it's a few questions here, but just scrolling all the way to the bottom, just to make sure we're covering everything. I'll give it another couple seconds and launch the results.
Sounds great. We'll just wait out a little bit before we get these all in. And
Two more.
Two more.
There you go.
Great. Let's see the results. Interesting mix. We've got a big group of people who feel that 72% of people feel that COVID-19 vaccines are safe, and about 28 people, or 28%, not 28 people, who are unsure at this point. So I'm glad that you all joined us tonight for this webinar to be able to answer any questions and to make you feel as comfortable as possible. If you feel like you're well informed, 67% said yes, 17% said no, and 17% are unsure. And are people worried about efficacy of vaccines for COVID-19? And this is interesting. We have a much more even split. 56% said that they are worried about it, and 44% said no. And do you have a preference between the COVID vaccines available for COVID-19? So 78% said yes, 22% said no. And once you become eligible, this is a very interesting question, will you get the COVID-19 vaccine? 50% of you said yes, 17% said that you don't know, and thankfully 33% of you have already had a chance to receive it, so congratulations. It'll be interesting to see afterwards when you complete polls as you leave the webinar to see if any of these numbers have changed. And thank you so much for participating in that. So I'll move on now to our agenda for tonight. So tonight's session is an informational webinar on COVID-19 and bleeding disorders, vaccine safety and guidelines, as well as access to vaccines. So when the pandemic first hit us in March of last year, we hosted a webinar on what was then known about COVID-19 and its relationship to bleeding disorders. And in fact, we had Dr. Jerry Teitel here to present as the main speaker to us that night. And he's here tonight again to reprise that role and to talk to us a bit more about that, as well as vaccine safety and efficacy. Dr. Teitel is the clinic director of St. Michael's Hospital Hemophilia Comprehensive Care Program, and he's been working for the bleeding disorder community for about 4 decades. We also have with us tonight David Gogolishvili. He's a Master of Public Health, the senior lead of the Knowledge Synthesis and Rapid Response Unit at the Ontario HIV Treatment Network. And he's been working there since 2010. So OHTN's Rapid Response Service provides access to research evidence and responses to questions from community-based HIV/AIDS organizations, policymakers, clinicians, researchers in Ontario to help support evidence-informed programs, service delivery, and policy. He's here tonight to give us the latest information on the provincial vaccine rollout, vaccine variants, vaccines, and HIV. So before I move on to our first presentation tonight, I'll just mention that after we have our presentations, we're going to have a question period where hopefully we're going to be able to get to all of your most pressing COVID-19 questions and vaccine questions. And we will also move on to the next slide. So here pictured, you have an example of a Twitter page, which for Vaccine Hunters Canada. Vaccine Hunters Canada is a volunteer group that came together to help connect Canadians to their vaccination centers, because there has been a lot of confusion in the rollout and information that's been going around. This group of volunteers started to aggregate data and push it out over Twitter to give people up-to-the-minute facts about where they can get access. So it's grown a lot in size. It was made recently, but you can see there are almost over 200,000 followers already, and people regularly receive updates from it. A member of our community got in touch with me about it to let me know about it, and I thought I would share it with you here tonight in case you are looking to find a way to see in your area if you're eligible and are looking to expedite that process as much as possible. If you go to the next slide. Vaccine Hunters Ontario is another Twitter account that basically retweets the Ontario-specific information from the Vaccine Hunters Canada page. The overall page can be a little bit overwhelming with notifications, so the Ontario one just curates information for Ontario. Let's move on to the next slide. So on screen there you have the two handles. Again, these are going to be provided and available to you on the website as slides and as member updates in our weekly member update, but I'll leave it here for another 5 seconds for you to take a look at before we move on. So thank you all for joining us again before we get started, and we're going to move on now to our first presentation, and I'm going to pass the screen over to Dr. Teitel. Thank you.
Thank you, Boyan, and it's a pleasure to be here with all of you. And I am going to, when I find it, I am going to, there we are. I'm going to share my screen. So you should be looking at my screen now. And I wish we could be meeting in person. I'm sorry, we miss you. I hate to sit in clinic all day and make phone calls, but that's what the reality has been lately. But we will get through this, and we'll look forward to seeing you all in person. So I'm going to give you today a presentation which is short, uncharacteristically short for me, partly or largely because I am not an expert in COVID-19, certainly. I'm not an infectious disease specialist. I'm not a virologist, but I'm going to focus a little bit on COVID and vaccine safety, specifically with respect to people with bleeding disorders, because that's why we're all here tonight. So I've called this little brief talk, COVID-19 Vaccines and Bleeding Disorders. What do the experts say? So let me show you who the kind of experts are that I am going to be citing. So this is a paper that came out in Hemophilia, which is the official journal of the World Federation of Hemophilia, not long ago. And you'll see the bona fides of the authors here and where this came from. So the authors belong to the World Federation of Hemophilia, the EHAD, which is the European Association, the European Hemophilia Consortium, the National Hemophilia Foundation, which is the national member organization of the United States. And you'll recognize many of these names. Here's our own David Page, Cedric Hermans, who's the lead editor of this journal, Mark Skinner, a former WFH president, as was, there's another president in here. So Brian O'Mahony was also president of WFH. He's one of the authors, and Glenn Pierce, who's the VP medical of the WFH. So this is a pretty august group of people. And what I'm going to do is just highlight some of the key points that came from this commentary that I want to outline for you and that I want to stress with you, and maybe this will stimulate some of the discussion afterwards. So the first point made in this review was that people with bleeding disorders are not at greater risk of contracting COVID-19 or for developing a severe form of the disease if they do get COVID-19. And for that reason, they're not considered a priority group for vaccination. The next point is that there's currently no reason to select a particular type of vaccine for bleeding disorder patients. Now, admittedly, this was written before the recent publicity around a rare complication, which is a thrombotic, a blood clotting complication, which I will come to in the next few slides, because I think the advice still stands. This is some simple practical advice. Pressure should be applied to the site, that means the site of vaccination, for at least 10 minutes post-injection to reduce bleeding and swelling. 10 minutes is a little bit long, but I think you all know the drill. It's the same thing we tell you when we advise you to get annual flu vaccines. We've always told you that. This is an important point here. There are no specific contraindications to vaccination related to complications of hemophilia and other bleeding disorders or their therapies. In other words, if you have hemophilia, von Willebrand disease, any other bleeding disorder, this is not a reason for you to be concerned about vaccination. And this is also important. If you are undergoing immune tolerance induction therapy, if you are being treated for hepatitis C or HIV, and our next speaker will speak more to this, I'm sure, or other conditions, these are not contraindications to vaccination. In fact, if I were being treated for HIV or hepatitis C, I would be more concerned about the effect of getting COVID-19 on my disease than I would be about the safety of vaccination. Another point is that vaccination is not contraindicated for patients on immunosuppressive drugs, although their immune responses and protection from infection may be reduced. That would apply very infrequently to people with hemophilia. Perhaps someone who is on immunosuppression as part of their immune tolerance regimen, which is unusual. Perhaps people with acquired hemophilia, which is a rare disorder, but we have many patients in our clinic who are on immune suppression for that, but we still do recommend vaccination. Here is pulled from the website of the National Hemophilia Foundation, the NHF, an additional comment which I'm putting in because this question has come up and I've been asked this question. It's a good one, and I think it's a reasonable additional point. Many of you with hemophilia A and hemophilia B are using factor concentrates, factor 8 and 9 concentrates, which are stabilized with polyethylene glycol, or PEG. This is a stabilizer, and this is a direct quote from the NHF website. This is a stabilizer that is used in many medications, including plasma-derived and recombinant factor products. Now, plasma-derived products are not pegylated, as we say, but the excipients, that is the materials which are used to stabilize them when they're reconstituted, contain trace amounts of PEG. Now, if you're using some of the pegylated factor 8 or 9 concentrates, that is the PEG molecule, polyethylene glycol, is deliberately attached to the factor 8 or factor 9, as you know, to prolong its survival in the blood. But the point here is made in the second sentence. Factor products that use PEG to extend the half-life of the factor product, or any factor products, are not a reason to not take a vaccine unless you have had a reaction to PEG. And there are very, very few reactions to PEG. It's been reported, but extremely rarely. I've certainly never seen it in any of our patients. And I'm not aware of any of our colleagues in Ontario or across Canada who have reported reactions to the newer pegylated product. So unless you are known to be allergic or to have a reaction to PEG, which is highly unlikely, don't worry about that. That question has come up and it's a reasonable one to ask. So what about this question now that has everyone excited for obvious reasons, because it's a dramatic and serious, although thankfully rare, adverse effect of vaccination. And this is the syndrome of blood clots. And the acronym that you'll see used for this is VITT, or VIT. That stands for vaccine-induced thrombotic thrombocytopenia. And it's a very rare syndrome in which the blood platelet count drops after as a complication of vaccination. But despite the low platelets, which you might think is a bleeding risk, in fact, the complications are blood clotting, that is thrombosis, rather than bleeding. And these are again, the august societies which have addressed this, and I'm going to show you some of the summaries of at least a quick overview of how this relates to bleeding disorders. So This is from the ISTH, the International Society of Thrombosis and Hemostasis. Here we have ASH, which is the American Society of Hematology, and here the World Federation of Hemophilia. They have all addressed this question. And here's a series of articles in the New England Journal of Medicine, which is, as you know, one of the leading medical journals that we all refer to. And there have been a series of reports on this rare complication, thrombotic thrombocytopenia, or VITT. And these AZ here stands for the Astrazeneca vaccine, with which it has been reported, and J&J is the Johnson & Johnson vaccine. These vaccines are related in the sense that they both use similar methodology for vaccination, different from the RNA vaccines, the Pfizer and Moderna vaccines, for example. These vaccines use adenoviral derived vectors for vaccination. It's the same technique, by the way, not adenovirus, a different viral vector, but it's a similar technique to the technique that is being used in all the gene therapy trials for hemophilia, these viral vectors to deliver DNA, in this case, to immunize against the virus that causes COVID-19. So here's a perspective on the risk of VITT. The incidence of the complication appears to be between 1 in 100,000 and 1 in a million. Let's say it's 1 in 100,000. There have been cases in Canada. There was one death in Quebec. So it is a potentially fatal complication, but the incidence is low, between, let's call it 1 in 100,000 to give you the maximum apparent incidence. And by comparison, so far in Ontario, and this is based on the Ontario database, and that is that your chance of dying if you get COVID-19 so far, this is overall through the whole pandemic, has been about 1 in 55. Now that number, I believe, is dropping because, of course, we had all these terrible deaths in group care homes and nursing homes in the first wave, people who had a higher mortality, they were older and sicker. But this is overall the death rate, 1 in 55. Your chance of having an adverse reaction of any kind to any COVID-19 vaccine is 1 in 2,440. Now, why am I so specific? Because I accessed the Ontario, this is the address at the bottom, the web address, Public Health Ontario this morning, so this is up to date, and this is the reports of adverse events related to COVID-19 vaccination, 1 in 2,440. Compare that to 1 in 100,000 for the risk of this thrombotic complication. Now, based on the mechanism of VITT, which we're starting to understand, it's complex, and I'm not going to bore you with the what we know about the mechanism so far, but based on the mechanism, hemophilia or other bleeding disorders, or even people who have clotting disorders, people who are prone to blood clots for other reasons, that does not increase or reduce the risk of this adverse effect. And there have, as I said, been fatalities, including one in Canada. Death is rare and the syndrome is treatable. Again, based on the mechanism and based on our experience with a similar mechanism in response to an anticoagulant drug, which we've known about for many decades, we do know how to treat it, and we do know how to get people through it, although it is potentially fatal. But the bottom line is, it's a mistake to be concerned about or to reject COVID-19 vaccination because you're afraid of getting a blood clot. Again, I'll just tell you, look at the odds. 1 in 100,000 risk of getting this complication, whereas your risk of having an adverse reaction to the vaccine, 1 in 2,000, your chance of dying in COVID, even if it's 1 in 100, that's a much higher risk. So I think that is the end of my presentation. So I'll turn it back to Boyan to continue.
Thank you so much, Dr. Teitel, for your presentation. And I'll now move it over to David to go forward with his presentation. Thank you.
Can you hear my, can you see my screen?
Yes, we can.
Yeah, okay, sorry, I was worried. Hello, everyone, and thank you very much for inviting me today for this talk. I have, my name is David, and I work at the Ontario HIV Treatment Network. And for tonight, I have pulled together some information that Boyan asked me regarding COVID-19 vaccines and what's current evidence related to their safety and effectiveness in people living with HIV or hemophilia. The hemophilia aspect of that has already been addressed by Dr. Teitel. And so I will be more concentrating on HIV aspect of it. But before we go to HIV, I have a small overview of all COVID-19 vaccines and what's going on right now around the world regarding this issue. So as you can see right now, so there are multiple COVID-19 vaccines that are under development right now throughout the world. And 92 as of today is the number of vaccines that are in clinical development. That means the later stages of testing those vaccines in clinical trials, whereas there are, in addition to that, 184 preclinical development vaccines in preclinical development. So most of the vaccines are protein subunit based, available in Canada. They mostly fall under two categories, which is RNA vaccines. There are 13 of them right now throughout the world under development. It doesn't mean that they are approved or authorized yet. I'll come back to that later. And viral vector non-replicated vaccines. There are right now 14 of them. Most of the vaccines require 2 shots, as you can see. There is one vaccine that currently that is under development that will require, if that gets approved, 3 doses. And there are 11 of them, including one that has been authorized in North America that requires only 1 dose. And the vast majority of the vaccines, the route of administration is intramuscular. That's 71% of all those 92 vaccines that are currently in clinical development. This includes the vaccines. This number 92 includes all the usual Pfizer, Astrazeneca, Moderna, and Johnson & Johnson vaccines that are approved in Canada as of now. So these, they're currently in the world, there are 13 vaccines that have been authorized by some authorization agencies such as countries or the World Health Organization or European Medicines Agency and so on. So please pay special attention to the first 4 rows because these are the ones that have been authorized in Canada. The first one is what's commonly known Pfizer-BioNTech vaccine or Pfizer vaccine. Then the other one is Moderna, Oxford AstraZeneca, and Janssen subsidiary, which is a subsidiary of Johnson & Johnson. So these are the 4 vaccines that have been largely authorized in almost all countries in European Union or North America or Australia. And in addition to that, as you may have heard, there are also other vaccines, mostly produced in Russia and China, Sputnik V being one of them. This has not been authorized in Western Europe or North America yet, as well as Chinese Sinovac vaccines. And on this list are the remaining out of those 13 that have not been authorized in North America or Europe. This is just here for your information, because I will be sharing all these slides with you so that you can have a look if you are interested. Also, I should say that everything that's underlined in my slide, it's a clickable slide, so that if you click on those, for example, here, COVID-19 vaccine tracker, it will take you to the actual website. So that if you are interested in more information, you could read about any of the piece of information that are in my slide. So now there are 2 more vaccines that require special attention. That's Novavax and CureVac that will probably be approved as well, but I don't know when in Canada, probably in the near future. Novavax is a US company and CureVac is a German company. So they have done phase 3 trials and they have submitted their documents for authorization in European Union, World Health Organization, or North America. So this is very interesting slide, I think, and it shows the share of people who received at least one dose of the COVID vaccine as of today, this morning. Actually, these are the data from this morning. They update this website every day. And so as you can see, Israel is the world leader. 62% of Israeli population have received at least one dose of the vaccine. United Kingdom is also pretty high up there, almost half of the population. US with 42%, and so on, so on. Canada is with 30.5%. And the following slide shows the actual vaccine doses administered throughout the world. So as of today, over 1.06 billion vaccine doses have been administered in the world. Out of this, 240 million almost in China, 232 million in US, and 12.5 million in Canada. Regarding COVID vaccination numbers in Canada, 12.7 million as of 9 a.m. today. Doses have been administered. 14.4 million doses have been delivered. That means that 88% of doses that have been delivered to provinces have been already administered. And just slightly more than 1 million Canadians have been fully vaccinated. In Ontario, 4.9 million doses have been administered, and that equals to about 33.3 thousand doses per 100,000 population. So this is a small overview of all currently, not all, but the most common currently available vaccines. This gives you some information about the technology that the vaccine uses, the suitability for people with weak immune system, number of doses. As you can see, all of them except Johnson & Johnson is 2 doses, and storage requirements. As you can see, mRNA vaccines require a very low temperature for storage, and the reason behind it is that they basically contain actual RNA that is very fragile, and that's why the RNA vaccines require temperatures that are below -20 or even -70 for Pfizer. And this is another iteration of my previous slide, just for your information, just a brief summary of all those vaccines. I took this slide from the BBC website. I liked it, and it's a brief overview of the most common vaccines. Now, I'm not gonna really go into details on the mechanism, how COVID-19 vaccines work, which are for in our reality, these are 2 vaccines, Pfizer and Moderna. But the major idea is that basically, instead of older technology, this is the first case when mRNA is used for vaccination of any type for any disease. And basically, what's happening is that the RNA is injected. The actual vial, the actual injection contains RNA that makes the cell to gives the instruction to cell to produce this spike protein, and then because of that, the body produces immune response, including antibodies to that. So now, you may have heard recently there is a talk about all kinds of COVID variants. So now, United States Centers for Disease Control and the Prevention basically categorizes all those variants into 3 groups. These are variants of interest and variants of concern, and then they also have introduced variant of high consequence. So currently, luckily, none of all those variants have been classified as high consequence, but there are many of them who are classified either by a variant of interest or variant of concern. So you may have heard about the UK variant, the Brazil variant, South African variant, and there are 2 California variants that are currently classified as variants of concern. And what that means is that they have an increased transmissibility or can cause more severe disease or significant reduction in neutralization by antibodies generated during previous infection or vaccination, and reduce the effectiveness of treatment or vaccines or diagnostic detection failures. So these are the 4 ones that to keep eye on: UK, Brazil, I'm sorry, 5 of them: UK, Brazil, South Africa, and 2 California ones. So now, this is actually the since February the 7th until yesterday, what is the percentage, or I should say, how common the mutations occur in Ontario settings. And you can see that, so these are basically the daily numbers here. Each column corresponds to 1 day of data. And you can see that the blue columns are pretty much represent the vast majority of current infections. That means that almost all cases that currently get spread in Ontario, they are already mutations. So the actual Wuhan virus that started about a year ago in China is not really circulating anymore in North America or in Europe, because there is nothing really that strange about it, because almost all viruses over time get mutated. Currently, there are, I'm not exactly sure about the number, but certainly over 1,000 different mutations. So, so that not to scare you, although the blue line, the blue part of the diagram is larger than anything else, that means that these are basically mutations, meaning that over the last 1 year, the COVID-19 virus has mutated and changed itself. And luckily, okay, I'll come to this back later, but most of the vaccines remain or seem to be remain pretty effective against almost all of those mutations. Okay, now let's go to COVID-19 and specifically a specific group of population, which is people living with HIV. So there have been many articles and many studies published on this subject for the last year, and different findings. Some of the studies said that they identified increased mortality or increased severity of disease in people living with HIV who get infected with COVID. Other studies, especially the initial studies, but the later as well, say that there is not really that much difference between general population and people living with HIV. This article came out about 2 weeks ago, and you can see that the Fauci, the head of National Institute for Allergy, he's very well known by now for most of the world's TB audiences. So the Fauci is the senior author on this article. And what they basically reviewed all the studies before that have been published before April 2021. And what they see is that although the totality of data is somewhat contradictory, it is nonetheless clear that COVID pandemic has a negative impact on people with HIV. The most consistent finding is that the severity of COVID disease in people with HIV is related strongly to the presence of comorbidities that increase the risk of severe disease in COVID-19, even in the absence of HIV. And there are multiple profiles of persons living with HIV, and the impact of COVID may differ for each of them. So, I should add to that is that although people with HIV who are on treatment with a normal CD4 cell count and suppressed viral load may not be at increased risk of serial illness, many people with HIV currently may have other conditions that increase their risk. One of them is the age. Currently, almost half of the people living with HIV in Canada are older than 50, which already puts these people under the elevated risk, even if they did not have HIV. And other chronic medical conditions are also common, such as cardiovascular and chronic lung disease that are more common in people with HIV. So the authors of this study actually created this table, and they assigned 1 star per risk category, given the somewhat conflicted data regarding each of these situations. The assignment of a risk is from 1 star to 4 star based on a broad interpretation of the weight of the data. And you can see that those with uncontrolled viremia or immune suppressed with comorbidities have the potential of a higher potential of severe COVID disease, whereas the ones on ART who are virologically suppressed and immune competent without comorbidities, they have the lowest potential for severe COVID-19 disease. Now, regarding the COVID-19 vaccines and people with HIV. So this seems to be a really long slide, but I'll go really quickly through them. As you know, there are 4 of them that are, as I mentioned, 4 of them that are currently authorized in Canada: Pfizer, Moderna, Oxford, Astrazeneca, and Johnson & Johnson. They all included people living with, okay, initially, actually, these people with HIV were excluded from all these trials, but then there was some advocacy campaign around it. And then these companies included them, but I should say not in large numbers. As you can see, Pfizer only had under 200 people, Moderna also under 180 with HIV, Oxford AstraZeneca 160, Johnson & Johnson over 1,200. And their findings, basically, I should say, okay, not many of them have published separate data of the participants with HIV. For example, Pfizer and Moderna have not published it yet. Pfizer published their trial results in New England Journal of Medicine, but they say that the analysis of sub-analysis of people living with HIV will be coming later. So same with Moderna and Oxford AstraZeneca. Actually, very recently, a few days ago, published 2 separate articles where they say that vaccine produced the same strengths of immune response in people with HIV and people without HIV, and therefore difference in the common vaccine side effects is basically non-existent. And people in both studies had, okay, important here is that people in both those Oxford AstraZeneca studies were basically immune competent. They had CD4 counts more than 500, and they were on antiretroviral treatment. So what the CDC does is that for people living with HIV, CDC recommends that because people with HIV may be at higher risk of serious illness, they can receive Pfizer, BioNTech, and Moderna vaccines. So they don't say anything about AstraZeneca because AstraZeneca, as you may know, is not approved in the US yet. So that's why CDC is not recommending it. So it's not yet known whether the level of protection among people with HIV is as strong as it will be, as it is for those without HIV. And care and treatment for COVID-19 in people with HIV should follow the same protocols as those people without HIV. Now, COVID vaccines for people. Now, Ontario reality. So people living with HIV are considered part of the Ontario's phase 2 priority group. They are classified under immune deficiencies and autoimmune disorders or immunocompromising health conditions. And they may be eligible based on other criteria such as age or where they live. For example, if they live in hotspots, then they can count as hotspot resident, whereas if they are over certain age, let's say 55, they can get it from a pharmacy and so on. There is no evidence that antiretrovirals will enhance or impair the response to the vaccine. And currently, there are several options in Ontario. Pharmacy for those aged 40 or over, people between 18 and 49 in hotspots. I'm sorry, I somehow did it twice here, the hotspot thing. Vaccination centers for eligible groups, and University Health Network Vaccine Registry also is currently open for pre-registration. But as far as I know, they are low on vaccine numbers. They don't have enough for everyone. And then also, actually, I already included this Vaccine Hunters Twitter and website because this morning the news came out that the city of Toronto has officially partnered with this volunteer group so that it can help people with not only with HIV, people navigate the very complicated COVID-19 vaccination rollout that is taking place in Ontario currently. So Here are a few additional resources if you would like to read more about HIV and COVID-19 vaccines. They are all linked. So once you get the slides, you will be able to just go directly to the linked pages. And okay, I'll skip this one. This is a National Advisory Committee on Immunization, so-called NACI. And they don't really say anything new. The one thing I would like to pay attention is that the relative degree of immunodeficiency who are immunocompromised varies depending on the underlying condition. I already mentioned that, the progression of disease and use of medications that support immune function. Therefore, in those cases, the balance of benefits and the risks must be made on a case-by-case basis. Now, I have a very short slide, actually, only one slide on bleeding disorders. Dr. Teitel has pretty much covered the whole thing. I just, here I put 3 different links where I took this information from. And you could go there and read more information about COVID vaccines and bleeding disorders, including hemophilia. But as Dr. Teitel already mentioned, there seems to be no reason to, first of all, to choose a particular type of vaccine. And also bleeding disorder is not a reason to avoid getting the vaccine. Boyan asked me to answer a few other questions that community members have apparently asked him. And these have been the rumors about the fertility and COVID-19 vaccines. Okay, there is really not there is no really any type of research really published on this yet, like in peer-reviewed journals or anything like that. This sentence that I've put in my slides, I took from the CDC website, and they say that if you are trying to become pregnant now or want to get pregnant in the future, you can receive COVID vaccine. Currently, no evidence that any vaccines, including COVID vaccines, cause fertility problems. There was also another thing about menstruation, because some professor, or I don't know who she was, from the US, put out a tweet saying that her menstruation and bleeding really dramatically increased after she got Moderna vaccine. And then this was basically snowballed. And there are many newspaper articles and blogs and everything right now circulating about whether COVID vaccination has any impact of menstruation. All I can, okay, I took the, I checked out the latest from the news agencies. As I said, there is not really much in published literature yet in terms of scientific reports or peer-reviewed articles or studies on that. So, and what I can say based on CBC, what CBC has reported, what the scientist online journal has reported and so on, is there is no evidence for COVID vaccination affecting the menstrual cycle. Does not mean that this evidence will not come in the future, but currently pretty much nobody knows for sure. And I was also asked to address this question about travel and COVID vaccinations. So now the World Health Organization says that vaccinated travelers should not be exempted from entry and quarantine requirements at this time. Canada says that, officially says that no exceptions for vaccinated travelers. But yesterday, I believe the news was, if you click on the link, that the Prime Minister said that vaccine passports to be expected, but Canada not ready to set terms yet. So we don't know, basically. On the other hand, US has already produced what official information, what they are going to do in terms of COVID vaccines, COVID passports, so-called, and travel. So if you are fully vaccinated with an FDA authorized vaccine or vaccine authorized by the WHO, you should continue to follow CDC recommendations for traveling safely. That means the masks and distancing and so on. Get tested 3 days after travel. I'm sorry. You do not need to get tested before leaving US unless your destination requires it. You don't need to self-quarantine after arriving back to the US. And all air passengers coming to the US, including US citizens and fully vaccinated people, required to have a negative COVID vaccine test no more 3 days before travel, or documentation of recovery from COVID-19 in the past 3 months before they board the flight to the US. So once you have that, let's say vaccine certificate or document that says that within the last 3 months you recovered from COVID, you are basically done. Regarding Europe, UK also apparently plans to use National Health Service phone application as a COVID vaccine passport, a passport certificate that will allow travel internationally. But as of today, there are no more details on that. European Union also apparently is in the talks with the United States about European plan to develop a type of international COVID-19 vaccine. And the European Union is planning to allow US citizens who are COVID vaccinated, fully vaccinated to enter Europe, whereas US seems to be the only country that has this kind of talk with the European Union right now. And Japan is also planning to introduce vaccine passports for international travel. This is all. Sorry if my presentation was too long, but I tried to capture all the questions and all the information that Boyan asked me. And as far as I know, Boyan got the request for all these questions from the community, from people. And I really hope that the information I provided sheds at least some light in this confused environment we have to live every day with all this new information basically coming. And I understand that it's really sometimes hard to make sense of all of that. Thank you.
Thank you so much, David. Appreciate that. And I don't think it was too long. I think you covered it, and it was good to have a general overview too of a bit of everything that's happening in the world, particularly, though not quite related to bleeding disorders. The travel one is dismaying and is going to be an interesting mess in the future.
Yes, I also think so.
Perfect. All right, so at this point, we're going to move on to the Q&A portion of the evening. We've had a number of questions already popping up in the Q&A. I'll encourage you all to submit your questions there. Just to mention that you are also able to submit your questions anonymously in case you're not comfortable answering under your own name, just in case that's something that's making you hesitate. So do you think we can move on to panel view, Kaylee, or is that already what everyone is seeing?
I need to unmute. You're all on panel now.
Okay, perfect. So top question on the list here is for Dr. Teitel. Dr. Teitel, would you recommend that you don't treat with factor products immediately before receiving the vaccine?
All right, so the question is negative. Do you recommend that you don't treat? No, I don't recommend that you don't treat. If you're on prophylaxis, continue your regular prophylaxis. It's not going to make you more susceptible to any kind of side effect. And in fact, if you've treated recently, you're less likely to have a bruise at the injection site. So yeah, go ahead and use your regular prophylactic regimen. I don't think if you're treating on demand and your hemophilia is not severe, I don't think you necessarily need to treat before the vaccine. It's a really small, thin needle. The gauge is so narrow, you don't even feel it going in, essentially. It's tiny.
Great. You answered this already, but it was reiterated here. Is St. Mike's currently offering in-clinic vaccinations at the hemophilia program?
No, that may be asked because of, as some of you know, we do sometimes give flu vaccines in the clinic, not the COVID vaccine. That is that's like done with military precision at vaccination sites. St. Michael's is a vaccination site. So you can register to be vaccinated at St. Mike's if you're in the catchment area or if you're one of our patients, but not in the clinic. No.
Perfect. Okay, so we have a very specific question here. I've received of somebody who's received a vaccine already. I've received the Astrazeneca vaccine and wondered if I have any symptoms related to a potential blood clot. Do I contact my HTC, my GP, or go to the ER?
Well, I guess the answer is it depends what your symptoms are. I mean, the symptoms can be subtle and can develop rapidly. If you've got alarming symptoms of any kind, you can always reach us. You're our patients, and if you're registered in our hemophilia program, you can reach us 24/7. We can help maybe put your mind at rest if we think it's nothing serious. But if you've got severe symptoms, go to your local emergency department. But you can always call us. I can't answer that specifically because, of course, it depends what kind of symptoms and how severe they are.
I'll actually follow up on that question just to ask, do you have a list of symptoms that people should watch out for if they fear that this might be something that's going on?
Right. I'll start by reiterating the incidence is 1 in 100,000. So, you know, I don't say, I'm not trying to be flippant, but what I tell people is, look, you're more likely to be hit by a streetcar on your way to get the vaccine than you are to get this complication. You know, God forbid any of that happens, but the odds are extremely remote. However, the symptoms, this causes blood clots in unusual places. It may be in veins in the abdomen. So you may get severe abdominal pain or nausea or vomiting. Sometimes the clots occur in the veins of the intracranially in the brain, in which case you might get severe headache. So those are the symptoms that are of most concern. And
I guess, I mean, most people probably know this, but worth saying, I guess, is that people may have a small reaction to the vaccine as their immune system activates to deal with it and to build immunity.
Right. So don't mistake that. This complication, the thrombosis that we're talking about, that occurs a week or 2 weeks after the vaccine, whereas any reaction you're going to get to the shot may occur immediately. I can tell you after, you know, I've had both shots. After my second shot, I was flat in my back the next day. I couldn't get up. I had a miserable day, but you know what? I was glad. It made me confident that my immune system was doing something. But that is not thrombosis. That's just a vaccine reaction, and that's a small price to pay.
Absolutely. All right, so we've got a very specific one next here too. I have a history of thrombotic events related to previous ports and PICC lines, as well as a previous inhibitor. Should I be worried if I receive Astrazeneca or J&J?
Yeah, I'm glad that was asked, because I can tell you the answer is clearly no. The mechanism of thrombosis that we were talking about, this VITT syndrome, is completely different from the typical mechanism of thrombosis. The reason you get thrombosis in your port or your PICC line is because of stasis, meaning the blood is not flowing, it's sitting there, and because you're injecting a high concentration of factor VIII or factor IX right at that site. PICC lines, or rather ports, are unfortunately notorious. About half of them will at some point develop thrombosis. That does not mean you are at risk for developing this rare complication. Even if you inherited a tendency to blood clots, these are syndromes that are kind of the opposite of hemophilia. If you've got factor V Leiden or prothrombin mutation, which are prothrombotic mutations, you are not at increased risk of this complication. So the answer to that is a definite no. Inhibitors, no, there's no reason to fear that complication either if you have had an inhibitor in the past.
Great. So, and I promise you this is going to be a theme now, but does COVID vaccine cause complication for people with G6PD?
No, it shouldn't. G6PD is an enzyme in red blood cells, and some people with G6PD deficiency are prone to anemia, sometimes related to some drugs or medications. So we're always careful about medications that will lead to an oxidizing potential, which can cause anemia in people with G6PD deficiency. I'm not aware of any, I'm not an expert in this field, but I'm not aware of other vaccines causing hemolysis or anemia in people with G6PD deficiency. And I've certainly not heard of it or seen it in, you know, these millions and millions and millions of doses of vaccine that David showed us have been administered worldwide.
Thank you. Now, this is actually a very, very interesting one. Does having a bleeding disorder make treating VITT more difficult if it were to occur?
That is an interesting question. Thankfully, I've never seen it reported in someone with a bleeding disorder, because it is a disorder of blood clotting. Although, as I said, the mechanism is unique and different from typical blood clots. I don't think so. The mechanism, or the treatment rather, I won't get into details of treatment, but it may include different forms of blood thinners. And we have used confidently blood thinners in people with hemophilia under many circumstances. And what we'll often do is just treat the hemophilia and give the blood thinner simultaneously. We do this routinely. Those of you who've had orthopedic surgery, for example, we likely gave you blood thinners after surgery. We have people with hemophilia who need blood thinners for other reasons, and we monitor them carefully, but we do have them on blood thinners. So the point is, it would be a challenge. And if someone with hemophilia, for example, developed this complication, the hemophilia expert would have to be involved in the treatment. Remember that, by the way, this complication occurs more often, considerably more often in women than in men, so they're not likely to have a severe bleeding disorder.
Thank you so much. All right, now we've got anything specific to hemophilia you would recommend if I get COVID-19?
Well, get the vaccine so you don't get severe COVID-19. That's my recommendation. But no, again, should someone with hemophilia end up with COVID-19, if you are sick enough to be in hospital, sometimes the treatment, as part of the treatment of COVID-19, does involve blood thinners, because COVID-19 itself is a strong risk factor for having blood clots. But again, with replacement therapy or with judicious attention to the management of the hemophilia, we would not withhold anticoagulation if it were necessary. But it would involve close collaboration between the infectious disease specialists, the hematologist, and other experts. But that's why we look after people in hospitals. We've got lots of smart people from different teams who all work together.
Thank you. That's well answered. Now, again, specific product question. Does Wilate and Humate-P have PEG? I had an anaphylactic reaction to Wilate.
Yeah, okay. So these are two plasma-derived products. Not all of you will know what they are. These are not pegylated products. In other words, the PEG is not attached to prolong the half-life. However, I don't know about those specifically, but many products do have tiny amounts of PEG in the material that's used to suspend them. It's not part of the drug itself. It's not part of the factor VIII or von Willebrand factor, but there may be traces of PEG there. PEG is everywhere. There's PEG in cosmetics, it's in lipsticks, it's in toothpaste, it's everywhere. We've all been exposed to PEG. If you have had an allergic reaction to a plasma-derived product, it is most likely to a plasma protein and not to PEG. But if you have had that reaction, what we like to do is have you assessed by a clinical immunologist to determine specifically what it is you're reacting to. We have certainly in the past, years ago, when we used to use more plasma and cryoprecipitate to treat people with bleeding disorders, we did have lots of allergic type reactions, but those were likely to debris from white blood cells contaminating the product. So it's likely not PEG that you are reacting to, but if there's a concern about that, then we have a clinical immunologist do the appropriate testing to see. Anti-PEG antibodies have been reported, but are quite rare.
That's super comprehensive. Now we've got one, I assume this is in relation to vaccines. That's how the question is phrased. Will existing hemophilia along with chronic thrombocytopenia increase the risk of blood clots?
No. The short answer is absolutely not. This is an idiosyncratic reaction, meaning we don't know what causes it. We don't know of any predisposing factor. I wish we did. If we knew what were predisposing factors, we'd be able to tell people who have those factors not to get vaccinated. But we don't know. But we do know, and we certainly can tell you from the mechanism, there's absolutely no reason to think that if you've got thrombocytopenia, which means low platelet count, if you've got hemophilia, if you've got a clotting disorder, none of those things predispose you to those thrombotic complications. And again, I'll just take this opportunity to remind you that thrombosis, clots, are quite common in people who have severe COVID. So your risks of getting a clot with COVID are enormously higher than your risks of getting a clot from a COVID vaccine.
Thank you. Here's going to go in with bleeding again here. Does Astrazeneca vaccine cause any issues for women with von Willebrands, like extra bleeding?
No. Short, I can answer that in one word. The answer is no.
Perfect. Can women who have had the Astrazeneca vaccine take tranexamic acid for menstruation in the week after the shot?
Yeah, it's a good question. And I would say yes, if you needed to control your periods, sure, I would say yes. If you take an extraordinarily rare scenario, let's say someone got the vaccine, was destined to get this, was the one person in 100,000 who was going to get this thrombotic syndrome, and they happen to be taking tranexamic acid at the same time, could it make the blood clotting a little bit worse? Possibly, yes. But I would say if you have severe periods and they're heavy and the tranexamic acid improves your lifestyle, the odds that anything bad is going to happen with that are so remote, I would not hesitate to take it should you need it.
So we've got another question here. It's slightly vague, but I'm anaphylactic to factor VIII products. I've heard some of the vaccines are not safe for me, but I need more info, please.
I think that goes back to the same question, Boyan. The only reason that it might be unsafe is this question of PEG. And why did PEG come up, by the way? Because there are, again, trace amounts of PEG in some of the COVID-19 vaccines, just as there are trace amounts of PEG in some factor products. We're not talking now about pegylated factor VIII and factor IX. We're talking about other products. So if you are known to be allergic to any, and all vaccines say this, all drugs say this, if you are allergic to any components, then don't have this. So if you are allergic to PEG, then you shouldn't have a vaccine that contains PEG. But that's kind of generic advice. And, I'll repeat, PEG allergy is quite rare. It's reported, it does occur, but it's quite rare.
Okay. Thank you very much. I think you're doing a lot to put people's minds at ease. So thank you for taking the time. How long do side effects last after getting a vaccine shot? I've noticed very slight headaches off and on the last couple of days since I got my vaccine last Thursday.
Typically not more than a couple of days. I'll return to my personal experience. 2 days later, I was feeling fine. So usually not more than a couple of days. I've spoken to lots of people who've had it, and I think that's typical. If after 2 or 3 days you're still having symptoms, I think it's unlikely that it's due to the vaccine. It's easy to have a symptom and say, gee, I got vaccines 4 days ago. Could it be due to the vaccine? The answer is probably not. So I would think more than if it's going on longer than that and you're concerned, then speak to your doctor, because it's probably not the vaccine that caused it.
Okay. Are the quote odds of VITT not further mitigated with reports that it has been seen to be most prevalent in younger females, assuming most hemophiliacs are males?
Yeah, good point, and that's absolutely true. Most of the cases involve women in the middle part of life, middle decades of adulthood. So a priori is true. Men with severe hemophilia are statistically less likely to get that complication. That's true, absolutely true.
Now, does taking birth control, tranexamic acid, and a COVID vaccine have any effect on individuals with a delta storage pool platelet disorder? Wow, super niche.
A very specific question about a form of platelet function defect that causes a mild or moderate bleeding disorder. Again, the answer is no. If you have this disorder and you're using birth control and tranexamic acid to control heavy periods, no reason to fear any of the COVID-19 vaccines. Go ahead and get it.
Okay. So somebody following up from a previous question that they made where they mentioned having an anaphylactic reaction. So if I had a severe reaction to factor, I should not get the vaccine unless I speak to a specialist.
I guess the answer really is it depends what it was that caused, what kind of reaction was it? Was it an allergic type reaction? And could it have been due to PEG or some other component that may be contained in the vaccine? And that's something that I can answer, but I think I can't answer, but I think a clinical immunologist should look into that. It depends what the reaction was. really, was it an allergic reaction? Was it some other kind of reaction that we can confidently say, no, that's not allergic. It has nothing to do with vaccination.
I wanted to go back quickly to something you mentioned in your presentation. You said that 1 in 2,440 may have experienced some kind of adverse reaction. I just wanted to clarify that. When you say that, you mean the full range of adverse reactions from the most mild to the most severe, basically, and then the severe reactions being different.
Yeah, so that address at the bottom that I put on that slide, Boyan, is from this Ontario website. They call this AEFI, Adverse Events Following Immunization. So I didn't look further to see what those are, but that's presumably all reported adverse events. Now, I didn't report that I, felt lousy a day after my vaccination, but that's not a serious event. So those are what is reported as of this morning. But those are all, it wasn't serious adverse events necessarily, it was AEFI. That's the acronym they use on that website, Adverse Events Following Immunization. So you can check that website yourself as well.
Okay. So I'm going to give you one that I got today from a member when that I spoke with. They asked me, they said, okay, so I'm not afraid of vaccines in general, but with these COVID vaccines, they're so new. What are the long-term effects of these COVID vaccines? Is that different from other vaccines?
Yeah. It's a fair question. As David showed in one of his slides, the RNA vaccines that are being used, 2 of them being used in this country, these are the first ever RNA vaccines that have ever been used. We've known about this concept, by the way, for 20 years. The concept is not new. Using RNA for vaccination and RNA therapeutically is a concept that's decades old, but these are the first ever RNA vaccines. I think the only DNA vaccine is the Ebola vaccine. Is that right, David? So you're muted, but
you're on mute, David.
Yeah, but the point is that these vaccines are new technologically. Was that right, David?
Yeah. Am I still muted?
No, we hear you.
Okay, so yes, it's absolutely correct that no other vaccines have used the RNA technology yet. Yeah. Although, as you said, this the technology have been in different kinds of research for almost 2 decades. I don't know exactly how, but it was used in cancer research before. And but in terms of vaccinations, no, RNA has never been used before. That's totally new. But I also should say about the DNA vaccine that you asked. Okay, as far as I know, there are 2 kinds of Ebola vaccines, and one of them is actually viral vector. I'm not sure about the other one. I don't know if the other one is really DNA vaccine or not.
Yeah, but the point is, so fine, the technology is new, but look, COVID-19 can be a devastating illness. We're learning it's not just necessarily an acute illness. It can cause chronic symptoms. And the clinical trials involve thousands and thousands of patients. And now we know that millions upon millions upon millions of doses have been used worldwide. And we're not seeing major or high-risk safety signals. Now, is something going to happen a year from now? I think if something terrible was going to happen, I think we would have seen a safety signal now, and we haven't. The science is sound. The science is good. We can't pretend that we've got long-term follow-up, but look, that's the way science progresses. We're treating a serious disease, a serious public health challenge, and a serious disease for people. Look at the deaths, the people we've lost over the last year and a half from COVID-19. If we can prevent it with what appear to be safe vaccines, I rushed to get it as soon as I could, and I encourage everyone else to do the same.
Speaking of mRNA, in the community, in the hemophilia community in particular, there's the issue of gene therapy. And so there's some questions around whether somebody who had taken an mRNA vaccine would be eligible for gene therapy trials.
That's a good question. You know, I'm sure the answer is going to be yes. I can tell you that the protocols were written, you know, before COVID. So the protocols don't have in the exclusion criteria, they don't say you may not be enter the trial if you have had an mRNA vaccine. So I don't think it will exclude anyone. I can't imagine that would be the case. I chair one of the data safety boards for one of the gene therapy trials. And if that question came to me, I would say, no, that shouldn't be an exclusion criterion. It's an interesting question, but.
Okay. Yeah, I think David also did some digging around the gene therapy around some of our, the WFH, and what was it you'd found?
Well, just give me a second. What I found was, okay. Let me read this.
Sorry to put you on the spot there.
Yes, no worries, no worries. So if considering enrolling in a gene therapy clinical trial, any vaccines that use a modified adeno-associated virus, AAV, should be avoided, since these viruses are used in gene therapy. But no vaccinations currently authorized are using AAV vectors or viruses. And Johnson & Johnson vaccine contains a type of human adenovirus, but adenovirus is not used in hemophilia on any form of gene therapy, and therefore is of no concern, including for those who are considering receiving gene therapy in the future.
Right. Yeah, you know, adenoviral vectors were used in the earliest gene therapy studies in hemophilia and other diseases in the early 2000s and were abandoned. They caused severe complications. And this has nothing to do with the DNA vaccines for COVID-19. So no gene therapy trials now for hemophilia or any other inherited disease use adenoviral vectors. And none of the COVID vaccines, as David said, use AAV, adeno-associated virus, and those are the viral vectors from which all the hemophilia gene therapy trials are being used. So no worries there.
Good. It's good to get some clarity on that one. One other thing I wanted to bring up, something we actually spoke about, was that a patient brought an issue where they were at a public health unit that had listed hemophilia or bleeding disorder as contraindicated with the vaccine, wrongly and kind of vaguely, not really explaining why or how. So I was wondering if you could just speak to that a bit, and if anybody, so if people encounter this from a public health unit that they're trying to get a vaccine from, how should they respond to this? What should they be armed with, and how do they proceed, essentially?
Yeah, yes, that was brought to my attention too. I was shocked to see it, but you didn't say it quite right. It wasn't that it was contraindicated, Boyan. What it said, if you have a bleeding disorder, you need clearance from your doctor to get the vaccine, which is kind of silly, really. And I did see that in print. So one public health unit, not Toronto, did specify that. You know, and when you look at the consent forms, I saw this when I signed my consent for my COVID vaccine. It says, it asks if you have a bleeding disorder. And the reason it asks that is because if you have a bleeding disorder and you get the vaccine, you might get a bruise at the injection site. That's the only reason. So they might tell you, oh, you've got a bleeding disorder, put pressure on the site, you know, hold it for 5 minutes while you're sitting there waiting to be cleared, because they have you sit there for 15 minutes before they let you go. Keep your hand on the site for a while so you don't get a bruise. That is the only reason. So don't be alarmed if you see that. I was afraid, gee, we might be inundated with calls. We have been inundated with calls, people concerned about COVID vaccine, but that is not anything to be frightened about. It's a bit of unfortunate that was put in that public health unit.
Okay, thank you. Now, I wanted to throw a general question to David about, just to maybe reiterate the ways in which you can get vaccinated in Ontario. what you can use to access. So I think there are about 5 different ways to do it at this point.
Sure. Can I share my screen?
Absolutely.
So the current options. So this comes from this website, which is Government of Ontario website, and there are different options here going on, and these things also change every time, right? Over with time, sometimes new options get introduced, sometimes not. So currently, what happens is that based on how old you are or where you live, you have different options. So pharmacy, for those aged 40 or over, you can book, but it's only Astrazeneca. And if you live in a hotspot and there is a list of postal codes, here is the list of all the postal codes that is counted as hotspot in all the regions of Ontario, including Toronto. Then over age 18, anyone can get vaccinated. Then there is, what is that? University Health Network Vaccine Registry. And this is also for a specific list of people who need to meet certain criteria. And as far as I know, they also have to be living in the catchment area of University Health Network. Okay, I'm not exactly sure about the details, but so that's so it's all linked. So people can have a look and see if they qualify to be vaccinated there. And so that's it as far as I know so far.
I guess I also meant like pop-up clinics and
vaccination centers for eligible. So pop-up clinics is pretty much the same as the hotspots.
Okay.
That's my understanding. So that they do pop-up clinics in those hotspot postal codes, but for the rest who do not live in the hotspots, for them it's also vaccination centers, but you have to meet certain other criteria, which are for phase 2 would be these. Do you see my shared screen?
Yes.
Yeah. Okay. So who is eligible? Older adults living with COVID in hotspot communities, people who live and work in high-risk congregate settings, caregivers in selected congregate settings, individuals with health conditions, and then within that they distinguish between highest risk, high risk, and at risk. If you ask me, it's a little bit random. There is not really much evidence to that clearly to distinguish what constitutes highest risk or high risk or at risk. But there is this whole list of different diseases that would qualify someone under one of those criteria, and then essential frontline workers and all that. So if you go to the link, the comprehensive list is there. I just didn't put them on the way on my slides because it really gets overwhelming. And if someone is really looking for it, if you click on the links and they go through them, as far as I can tell, the only real problem currently is that the vaccine supply is pretty low, and that creates a lot of bottlenecks and so on. I personally tried to get COVID Astrazeneca vaccine from a pharmacy, and after 10 days now, I have not heard back. So I pre-registered, but so I have not heard back. I was told, okay, when you literally pre-register yourself there, it says we'll get back in touch with you within several weeks or several months. Now every day the news comes out that soon we'll be getting more vaccines. Even today, I think there was Bogoch interview. He said Pfizer is coming in several million doses of it. We don't know when. So it's really, someone really needs to navigate the system to get something that's available to them, especially for them who are not the highest priority group, as would be people aged 65, I believe it was. That there it went more or less smoothly, but for everyone else, with people other diseases, it's a bit complicated and challenged to find what's available for whom and where.
Thanks for kind of outlining that. Now, somebody's piggybacking on that explanation and asking here, is prophylaxis home care considered adults receiving home care services for getting the vaccine earlier? So I guess basically they're asking, do they fall within this category that might get them higher priority because they are on home care prophylaxis?
You mean hemophilia prophylaxis, factory
Yes.
infection prophylaxis?
Yeah.
No, I don't think that doesn't make you, you know, I think as we both showed in our presentations, hemophilia doesn't make you higher risk, and the fact that you're on home infusion is great, but no, it doesn't make you higher risk or higher priority. No.
Okay, thank you. So that brings us to the end of our questions, and I want to thank you both so much for making time to be with us here and to shed some light on this and confusing times to the community and taking your time to do that. Thank you everyone for attending, and I would just want to say, please, if you can, once you leave the meeting, you'll be redirected to a questionnaire to answer a lot of the same questions that you answered before, so that we have an idea of what impact this webinar had on you, as well as replying to us about how good of a job we did in putting it together. Thank you so much, everybody, and I'll just reiterate that the Vax Hunters Twitter is a good resource for agglomerating the data, especially with the changing conditions. They shoot out tweets on a regular basis. If you're somebody who uses Twitter, it's very useful and can be a way to, on short notice, source when there's vaccine available, if that's something that's a real priority for you, which I hope it is. All right. Thank you, everybody.
Thank you
Have a
very
great
much.
night.
Stay safe.
Bye-bye.